Değerli konuklarımız, hepinize bir kere daha hoş geldiniz diyoruz salonumuza. Sıradaki panelimiz spor sağlığı, modern futbolda sponsorluğu konusunda olacak. Öncelikle sahneye konuşmacılarımızı yine davet ediyorum ve yine bir online bağlantımız gerçekleşecek bu panelde de. İlk konuşmacımız iMove firmasından online şekilde katılacak Antonio Tramulas. Yine online olarak aramıza katılacak olan bir diğer konuşmacımız Celeste Gertsema ve sahneye alkışlarınızla Hacettepe Üniversitesi öğretim görevlisi Sayın Gürhan Dönmez Beyefendi'yi davet ediyorum. Ve yine bugün aramızda olan kardiyoloji cerrahı Prof.Dr. Sayın Giulo POMPILIO Beyefendi yine sizlerin güçlü alkışlarıyla sahneye davet ediyorum. Ve bu panelimizin moderatörü de yine çok değerli bir konuğumuz. Kendisi Gloria Sports Arena'nın medikal direktörü. Yine alkışlarınız Sayın Prof.Dr. Emin ERGEN Beyefendi'ye gidiyor ve sözü kendisine bırakıyorum.
Thank you very much. I just would like to thank the organizing committee to have me here as the moderator and all the speakers accepting our invitation for their kindness. So ladies and gentlemen, this session is going to be about the health of football players. We have 4 distinguished speakers and I hope you will enjoy listening to them. So our first speaker is Dr. Antonio Tramulas from Spain. You see him on the screen. Welcome, Tony. Good to see you.
Me too.
Yeah.
I mean, me too, and thank you for inviting me.
Pleasure. Dr. Tramulas is a sports medicine physician from Spain, from Barcelona. So now you may also wonder if he has anything to do with Barcelona Football Club. Yes, he was formerly responsible for sports medicine services in Barcelona Football Club between 2004 and 2007. So, but moreover, he worked with Barcelona basketball team between 1998 and 2004. Actually, Dr. Tramulas was a professional basketball player at Barcelona before he started his career as a physician. So in the meantime, he was a very good friend of Johan Cruyff, and after working as the head of Aspire Sports Academy Medical Center between 2013 and 2019, he started working with Xabi Alonso, if I'm not wrong, Tony, in Al Sadd Sport Club.
Yeah, Xavi Hernandez.
Sorry, Xabi Hernandez, yes.
Xavi Alonso is another country. Well, I'm sorry,
Yeah,
it's Madrid.
sorry, yes, okay. So he worked with Xabi in Al Sadd, actually the champion of Star League in Qatar. Now he's back home and working at iMove Sports Clinic. I'm really fortunate. I worked with Dr. Tramulas for years in hospital and I witnessed his strong commitment to young kids and also elite players. And I'm sure that it will be very interesting listening to him about his experience. Ladies and gentlemen, please welcome Dr. Tramulas in the screen. He couldn't come to Antalya because of the Omicron, hit his family, a couple of members. So he, hopefully we're gonna have him next time. So, floor is yours, Antonio.
Thank you so much, Emin, and thank you to the organizing committee to inviting me to come. I will not miss Antalya, so I will come back soon when possible. And I want to just apologize because for those who expect from my side a masterclass will be just a vision and opinion coming from my experience, my humble experience during all these years, okay? So the title is Sports Medicine and Performance Department. Why? Because they cannot be separated. And this is the main pillar of the conversation now. Sports medicine and performance, there is no performance without health, without sports medicine. And these days we are seeing that there is no health without performance, maybe. So that's why the leadership should bring both both, let's say, pillars, sports medicine, health, and performance together to integrate. So let me talk about the philosophy that I like and I appreciate, the organization, the operational, and the summary of this talk. About the philosophy, these not negotiable qualities. I think we should think about good people and good professionals, of course, but good people. Share leadership. I want to lead with other leaders that know much more than me in different fields. I think the sports medicine and performance should be invisible. We have to be there, but we cannot be, let's say, the main people in the room. No, we work for the coach, we work for the players, and of course, confidentiality is a basic thing. We have to enjoy working. Cruyff used to say, it's not difficult to do things right. If you are an organized person and common sense, usually you can do good things. But if you want to do it with excellency, the only thing is you have to feel passion for your job. Is the next step, passion for the job. And teamwork, but working as a team. Teamwork is a word that many people knows, but not many knows the meaning. It's to work as a team. And the team can be football players, can be a basketball players, can be a group of doctors, can be a group. And teamwork is to help to the other ones for the benefit of the group. And of course, me, it's an old-fashioned thing. It's us. About the organizational structure, I think it's important. The sports medicine and performance department director should come straight from the board, not from the sportive area, from the board, because it's an add value of the club. It's something that can be improved, but has to be stable in the club to provide service to different coaches, not only football. Some clubs in Turkey, some clubs in Barcelona and Madrid and different countries, they have a club with different sports. Like Barcelona, they have one of the best in football and handball, basketball, roller hockey, etc. So it should come straight from the board. And this sports medicine and performance director, I think, could lead these 6 main pillars. And of course, in the middle, the sports medicine and sports performance, and one of the most important pillars. But on the left side, we have external consultants. That means a network of different specialties that we need, or we can just talk to them and ask for a second opinion. A research and development department. On the right side, we have a technology and innovation department and a sports medicine and performance center to organize camps and events. And again, the 2 main pillars of this sports medicine and performance is the sports medicine, health, and performance. And they are intimate related on both sides. For instance, in the sports medicine department, we were talking about sports medicine, orthopedic surgery, physiotherapy, physiology, nursing, podiatry, radiology, regenerative medicine, laboratories, an example of different specialties, different jobs inside the sports medicine department working for the health of the athlete. And on the sports performance department, we have strength and conditioning coach, internal load measurements, external load, return to play, nutrition, neuroscience, psychologists, support technology, artificial intelligence, all these areas, let's say, belongs to sports medicine and sports performance in that case. But both pillars are integrated, should be integrated, because we cannot differentiate. We just mentioned before, without health, there is no performance. But without performance, maybe there is no health. So these 6 pillars are the main pillars in this structure. But more than this, because if this sports medicine and performance department has the 2 main pillars, sports medicine and performance, we need to educate and create a future talent to helping us and belongs to the institution in the future. So should be perfect to organize the Sports Medicine and Performance Institute to just educate other people that will follow us in the future. About the organizational structure. Okay, we have the Director of Sports Medicine and Performance Department with the two main pillars, head of sports medicine and one head of sports performance. In the head of sports medicine side, we have external consultants, we have research, we have physiotherapy, we have the medical center. And on the head of sports performance side, we have physiology, technology and innovation, psychology, neuroscience, strength and conditioning, sports science, nutrition, CAM and events. Okay, let's see how to organize. And again, we cannot separate both. That's why, in my humble opinion, the director should be the same. Of course, maybe a sports medicine physician with a wide vision and a wide idea about both health and performance, and selecting the right persons to lead the sports medicine side and to lead the sports performance side. And again, the head of a sports medicine area, we are talking about this, for instance, 4 main pillars. So these 4 units, the sports medicine with a number of sports physicians, physiotherapy with the physiotherapist and a lead physiotherapist, the research and development group, just to organize all the research and investigation about the data that we need and what happened, the injury prevention, the internal load, the external load, etc. And the external medical network. I think I'm lucky because I have many, many good friends around the world that I can just hang the phone and take the phone and make a phone call and ask for a second opinion, or maybe send a player for a second opinion. And this is very important. If we talk about the sports performance structure, we are talking about one head of the sports performance area. And with this, for example, these 7 units, physiology, to understand the physiological demands of the team, the physiological demands of this sport, and the physiological demands of the way they play, the philosophy of the team, the football team. I strongly believe that the philosophy of the game for Barcelona, it's completely different maybe from Atletico de Madrid. So the physiological demands maybe are different, or maybe they have more mental demands. Anyway, physiological unit, technology and innovation unit, psychological and neuroscience unit, strength and conditioning, sports science, sports scientists network, and camps and events. This would be the head of sports performance area units under his guidance. To provide service to who? To provide service to the elite athletes, can be the first teams, can be registered athletes, not the first teams, but they compete against other cities, other teams, other countries even, the youth athletes, and we cannot forget the staff that we have in the club. And on both sides on the top, we have on the left side, sports medicine and performance department network. Again, we should share ideas, we should share situations to learn from others and just have a group of people in a network that can support us in certain moments. And on the right, on the top, we have a sports medicine and performance department hub, maybe to organize conferences like Antalya, like workshops, etc. Let's focus on both the elite athletes and youth athletes. And let's start with the youth athletes. With the youth athletes, I suggest this kind of organization. The Sports Medicine Performance Center that will be in the club will have sports medicine personnel, return to play professionals, psychological professionals, podiatry, internal medicine, functional adaptation, physiotherapy, nutrition, nursing, radiology, events coverage, and regenerative medicine. Okay, from this group of people, this group of specialties, at that time, okay, will be like this. Let me go back a little bit. Okay, this sports medicine performance in youth will have this specialty that you mentioned before, but adapted to the youth. So will be a functional group coming from this group of different specialties in the sports medicine and performance department, specialized on adolescents. Can be the sports medicine as well as a pediatrician, can be a sports medicine physician with skills on adolescents as well, physiotherapists, skill on adolescents, management of injuries, psychological approach for adolescents, etc. I mean, it's a functional group specialized for youth athletes. For youth athletes to provide this information to the youth academy. This group will work to the youth academy or will work to the target athletes and will work to the scouting department of the club to give an additional information, an important information, more than if it's a right-footed or left-footed, it's a good with long shoots or heading, or more than this, we need to provide, and we can provide very useful information in order to select people for the club. This group of the youth academy, the youth athletes, will do periodic evaluations like medical screening, musculoskeletal screening, physiological screening, growth and maturation status, psychological screening, important in adolescents especially, cognitive screening, and nutrition evaluation. All this periodic evaluation should perform 3 or 4 times a season. And this information will go to the teams just to provide to the professionals in each team just to take the actions based on the results. For instance, the medical screening can include the health profile, a psychological profile, an injury risk status, weak points of the player, training individualization, healthy habits education, results evolution monitoring, and supplementation to these youth athletes. But another important field, the growth and maturation status of the players. You know that all these players that we saw play and we enjoyed playing a few years ago all together in FC Barcelona came from the academy. And it's important to understand the growth and maturation status of the players, of course, and different between males and females. We need to monitor this. We need to monitor because, and nowadays, these days, Barcelona, maybe they are playing now with 6 or 7 or 8 adolescent players. They need a special regime for them in terms of training, in terms of recovery, in terms of mental health. No? We can implement, of course, performance tests. For example, strength, speed, agility, endurance, balance, mobility. All these tests can be recorded and can be monitored during the season for 3 or 4 times and provide these results to the specific coaches. One more important thing, and this is a way to measure all these 5 different performance tests, is as an example. An important thing, I love this. We were talking early this morning, and I was listening from Chris Barnes, and I love the talk and the advice and the experience of Chris. And I fully agree that football, basketball, they are sports, of course, but they are games. It's a football game, it's a basketball game. We need to teach, or we need to monitor how the players can learn if they have a facility to learn, and how can improve the learning of the game. No? So the spatial intelligence assessment, I think it's one of the important things, and we can innovate on this, just detecting and training the ability to understand the space. we all know that some, let's say, players that, oh my God, this player is very lucky. All the balls come to him. No, maybe it's not. Maybe he has a special intelligence to understand and in advance to know where it's going to be the ball. No, it happens the same with basketball. Oh, this player, they catch all the rebounds. Maybe it's not by chance. It's because he, in advance, understand and know where is going to be the ball. So this is a special intelligence that it's very important for instance, the philosophy of football game in FC Barcelona. It's related to space. We need to know. We need to think about players like Xavi, like Iniesta, like Busquets, and many other from the Premier, but they have a special quality. They have a special intelligence. It was first studied in the States with Gretzky, a hockey player who had an amazing special intelligence and was very useful for the team. So we start developing a study with two, let's say, items. One, the neuro tracker. It's a visual training. At the same time, you do another action. And we measure the EEG waves through this brain lab technology, like neuroleptics. It's just measure the waves wireless, the waves of the brain, to understand what happened when the players decide and takes decision making, and to see what happened. So these two technologies combined can give us which player is ready for this and which player can improve this spatial intelligence. Okay, this is related to youth. If we talk now about the elite athletes, the elite team, the first teams of the club, and we just write down two different, let's say, not different, but two different teams, the sports medicine staff and the sports performance staff. Again, both, it's one team. It's not two teams. Both are related. From the sports medicine staff in elite team, we can have orthopedic surgeon. I think it's very important. Related to the team, maybe it's not a full-time surgeon, not to operate the players, just to have a surgical opinion defending the players and the club. With two sports medicine physician, one of them head, just to combine the trips, and maybe 6 physiotherapists, two field rehab physiotherapists, one nurse, one podiatrist. This is an example about the medical, that means health, organization in a team, in a professional team. If we talk about the sports performance staff, we talk about the team strength and conditioning person, the coadjuvant strength and conditioning, maybe the gym exercise, the optimization strength and conditioning, the load control, the S&C just based on the load control measurements, the psychologist, the nutritionist, the physiologist. These are people on the performance side, let's say. From these two groups that we know that will be one group, and we'll see visual later on, they make, or I suggest to make a functional team again to do the recovery unit. The recovery unit to recover from the games, after the games. Depends on what kind of game, depends on the demands of the game. Of course, in a individualized measure and individualized way, because we need to organize a recovery to the players in one-on-one base. But it's one question, what they have to recover. We're talking about recovery unit when we don't know what do we have to recover. For this reason, I suggest a functional team with the sports medicine, the head physiotherapy, the head of strength conditioning, the psychologist, the nutritionist, the physiologist, just to design after the game, based on the physiological demands of the game, what kind of recovery every player needs. Maybe one player just needs a conversation with the psychologist just to understand how he missed 5 times the goal, clear goal. Okay, so the recovery unit in these days, that when the most important clubs in Europe, they are playing a game every 3, 4, 5 days maximum, usually 3 days, it's very important, the recovery. So the operative, in other words, should be like this. We have on the left side, we have sports medicine, that means health. And on the right side, we have sports performance. And on the sports medicine left side, we have many actions that can be done based on, let's say, health, no? Radiology diagnosis, surgery, biological therapies, medical treatment, medication management, cure, podiatry, biomechanics, manual therapy, rehabilitation, functional training. Just an example, screening, massage, post-recovery, hydrotherapy. These are actions on the sports medicine side, right? On the left side, the sports performance side, we have different actions to do. Strength training, specific training, technical, tactical training, functional integration, psychological training, nutrition assessment, supplementation for the players, load control, physiological control, spatial intelligence, sleep monitoring, data analysis. We can consider all these actions on the sports performance side. So we have in theory, two differentiate groups, no? Sports medicine health and sports performance, but it's not right. Why? Because these actions on the left side, on the health side, on the sports medicine side, some of the actions are closer to the sports performance. At the same time, these actions on the sports performance side are closer to the sports medicine side. That's why we cannot separate health and sports medicine and performance. That's why the director or the leader of this group should be one leader for both, with very skilled people on both sides. In other words, if we have on a daily basis what a team can be done during the day, let's say we can do something about prevention, we can do actions for the functional readaptation, we can do something for the recovery, we can do on the right side something about sports performance and something on the left side about diagnosis and treatment. This is what happens on a daily basis in the locker room, no? In the activity of the team. And now we put the professionals and we put on the left side, on the diagnosis and treatment, on the sports, clearly the sports medicine side, we put the group that we just mentioned before, no? And on the right side, on the sport performance side, we put the professionals in charge of all this that we mentioned before, okay? But what happened? What happened is some of the sports medicine group are skilled on different things that affect different things on the daily activity. Some physiotherapists are more skilled on the prevention, or some of them are more skilled on the field rehab, or some of them are more skilled on the couch doing a manual treatment. No, the same on the performance side. These specialized people, skilled people, some of the skillness of these people are closer to different areas. So that's why we cannot separate performance and sports medicine. We cannot separate performance and health. Okay, as a summary, I have been talking about few things. One, human power skills versus CVs. It's important, the knowledge, it's important, the CV, but it's more important, I would say, on a regular skills, on regular knowledge, of course, these human and power skills. In an old days, or not very old, but some of them older, called soft skills. Soft skills, but it's a, let's say, a pejorative word, so they changed to power skills. Power skills is something like communication ability, no? Communication as a teamwork, as decision-making, organized, adaptability, leadership, creativity. These are power skills, very important in addition to the knowledge. we have been talking about youth athletes, the importance, the elite athletes, the first teams, and the sustainability these days. It's a very important problem, or a very important, let's say, field in a club. So let's say human and power skills to make more than a team. Youth athletes, because it's their values. The elite athletes is the face of the club, no? It's the high performance phase. And resource and profitability, of course, these days with the pandemic and the crisis, I think it's very important to think about this. And as Emin just mentioned, I had the privilege to be a close friend of and manage some of his old or his late, let's say, illness that finally made him pass away, of Johan Cruyff. Johan Cruyff can be remembered as a very good player, a very good coach, but more than this, it's remembered because of his legacy. And I think it's something that we need to understand and think about this when we organize the sports medicine and performance area of a club, to leave a legacy there. The important thing of Cruyff is the legacy. The legacy, one of the main persons under his legacy is Pep Guardiola's. So we need to leave something in the club for other people coming after us can just improve the legacy that we can leave in the club. That's why I need to be the sports medicine and performance department coming straight from the board of the club, not from a coach. So all this, let's say, humble vision and opinion about these things come from my experience in the FC Barcelona basketball team, FC Barcelona football team, 8 years in the academy as a medical director, and true, as a basketball player, former basketball player, not with FC Barcelona, in Barcelona for 15 seasons. I was not too tall, but I was very smart, joking. And this is my humble, let's say, delivery of this, not a masterclass, but yes, an opinion and maybe a different vision that, coming from my experience, I can share with you, because I think it's the way to organize. And I think it's the way to organize. And more than this, I will never accept a different other way. Why? Because one of the last quotes from Johan I learned, because we never talk about football, we talk about life. It's this: it's better to go down with your own vision than with someone else's. So follow your instinct, be strict and strong with your ideas. Go through, and share all the knowledge with the team. This is a teamwork, and to provide the service and our support to the coach at the end is the ultimate responsible for the performance of the team, no? But as well for the players, for the patients. Thank you so much. I mean, this is my humble presentation to you.
Tony, thank you very much. Not only a practical, informative talk, but also inspiring based on your experience. Thank you so much.
You're welcome.
Please don't leave. There may be some questions at the end. Now, ladies and gentlemen, I would like to continue by introducing my very good friend from Hacettepe University, Dr. Gürhan DÖNMEZ. He is a sports physician and associate professor at Hacettepe University in Ankara. And he has combined his clinical skills with his experience as team physician by working with several football clubs like Gençler Birliği, Ankaragücü, Çaykur, Rizespor previously. He has an in-depth experience in injuries, diagnosis, treatment, rehabilitation, and also prevention. And of course, return to sports after the injury. So in addition, having been involved in all these activities for a long time, he is very much interested in carrying out research projects in relation to football injuries, One of his interests was to understand the seriousness of an injury occurring in the field when a player is down in the field, so someone needs to attend, of course, and the casualty should be saved, whatever, and then make a decision. So he will talk about the importance of field side observation and decision when it happens. So floor is yours, Gürhan, please.
Thank you, Professor Ergen. Thank you so much, and also thank you for all audience for sharing your time at that time today. Before I start my speech, I want to ask, because we have some foreign friends here, their native language is not Turkish, but if they allow me, Chris, Kasper, Julio, if you allow me, it will be a pleasure for me to speak in my native language, and if it is not problem, and I will start in Turkish. Teşekkür ederim hocam. Öncelikle aslında konuşmam söylediğiniz Celeste'in konuşmasıydı. Benim konuşmam biraz daha farklı olacak. Sahadaki takım doktor olarak başımıza gelen uygulamalardan ya da işte senaryolardan yaptığımız bir çalışmadan bahsedeceğim. Ben de kısaca aslında hocam özetledi ama kendimden bahsedeyim. Ben son 7 sezon Türkiye Süper Ligi'nde çeşitli kulüplerde futbol takım doktorluğu yaptım. Onun haricinde de Türkiye A milli kadın basketbol takımı, A milli kadın futbol takımı, rugby ve beyzbol gibi farklı branşlarda da yine milli takım doktorluğu görevlerim oldu ve çok şey geldi aslında başıma. Bugün biliyorum içeride sadece hekimler değil, antrenör arkadaşlar var, işte spor bilimciler var. Hemen hemen herkesin ilgisini çekebilecek bir konuşma hazırlamaya çalıştım. Hatta kameraman arkadaşlardan, işte tercüman arkadaşlara kadar futbolla az çok ilgilenen herkese hem dinleyebilecekleri keyifli hem de belki de ileride para kazanmayla ilgili birkaç ufak trip verebilirim diye tahmin ediyorum. Sağ kenarında olmak, yani çizginin diğer tarafında olmak aslında eğer ki futbolu da seviyorsanız, ki hepimizin aslında bu işi severek yaptığını düşünüyorum ben. Bizim için de oldukça keyifli bir iş. Ben de en sevdiğim iş, en sevdiğim şey diyeyim, hobim aslında futbol. Ve hobimi işim olarak da yapıyor olmak bana ayrı bir keyif veriyor ama çoğu zaman şununla karşılaşıyoruz. İşte benim 5 yaşındaki oğlum bile benim yaptığım işi biraz da işte içeriye gidiyorsun baba, işte sporcuya bir sihirli bir sprey sıkıyorsun ve bundan ibaret. Yani herkes çocuğunun gözünde bir kahraman olmak ister ama benim küçük oğlum beni sadece sprey sıkan bir baba profili olarak tanıyor. Gerçekten de biz sahaya girdiğimizde neler yapıyoruz? Bugün biraz ondan bahsedeceğim. 2015'ten itibaren 4 yıl süreyle 266 tane maç, yanlış hatırlamıyorsam 266 maçta benim ve doktor arkadaşımız, doktor abimiz Savaş Kudaş'ın takımlarının tüm sahaya giriş ve bizim yaptığımız sahadaki tedavilerle ilgili, olası senaryolarla ilgili deneyimlerimi size paylaşacağım. Aslında çalışmaya başlamadan önce benim kafamda hep bu vardı, böyle bir şeyi araştırmak, ne yapılmış olabilir diye. Düşündüm de ne kadar olabilir diye tahminim. Yani çünkü sürekli işte futbol maçı izliyorum ki daha çok böyle Avrupa ligleri, işte Şampiyonlar Ligi, Dünya Kupaları. Kafamdan geçen rakam aslında 1,5, belki bilemediniz 2 gibi bir rakamdı. Türkiye, hep Türksel diyorum sanki sponsor almış gibi. Türkiye Süper Ligi'nde şunu gördük. Her maç ortalama olarak, tabii ki bu bazen hiç de olmayabildi, bazen çok daha fazla olabildi. Ortalama 3 defa sağlık ekiplerinin tedavi ihtiyacı nedeniyle sahaya girdiğini gördük. Bir sezon ikimizin takımı da, hem Savaş abi hem benim takımım 1. lige düştü ve sonrasındaki sezon tekrar çıkmıştık. O yüzden bir alt ligi de değerlendirme şansımız oldu ki bu aslında çok önemli bir kriter. Çünkü alt liglere doğru gittikçe de biz Türkiye Ligi'ni konuşuyoruz. Daha böyle Avrupa Ligi, Dünya Şampiyonları, Dünya Kupalarını konuştuğumuzda aslında oranın daha da azaldığını birazdan göreceksiniz. Alt liglere gittiğimizde yaklaşık 4 defa her maçın ortalama bu sebepten durduğunu görmüş olduk. Merak ettik. Dünya kupalarında bu ne olmuştur diye araştırdık. Son 2 Dünya Kupası aslında hem erkeklerde hem kadınlarda. Rusya'daki 2018 Dünya Kupası'nda bu oranın 1,9 olduğunu gördük. Görüyorsunuz neredeyse bir giriş, hatta birden daha fazla Türkiye Ligi'ne göre daha az. Kadınlarda da yaklaşık bizim Türkiye 1. Ligi'ne yakın oranda 2,7 civarında bir sahaya giriş gördük. Peki bu neden önemli? Elbette bundan değil ama ben bu arada size o ufak bilgiyi de vermiş olayım. Eğer ki böyle bir bahisle karşılaşırsanız bir gün hayatınızda ve para kazanmak istiyorsanız, Türkiye Ligi'ndeki böyle bir bahise oynadığınızda kazanma şansınız, eğer ki sağlık ekibi sahaya girer diye oynarsanız %97. Para kazanmak için güzel bir yol. Dünya Kupası için oynarsanız yaklaşık %89. Ama tabii şunu da söyleyeyim, yani şaka bir yana, hep derler neydi işte, kumardan zengin, milyoner olan sadece bir kişi tanıdım, o da eskiden milyarderdi diye. Siz yine de bahisten biraz uzak durun. Peki bir maç esnasında kaç defa en fazla sayıda sahaya girilmiştir diye baktığımızda bu 266 maçta ki toplamda incelediğimiz yaralanma sayısı 956 ya da 956 olay diyeyim. Tek seferde sahaya girilen maç sayısı maksimum olarak 9 defa girmiş. Yani düşünün bir maç izliyorsunuz, ekranınızın karşısındasınız ve 9 defa içeri doktor giriyor çıkıyor, doktor giriyor çıkıyor. Bu hakikaten oldukça can sıkıcı bir şey. Çünkü insan futbol izlemek için ekran başına geçtiği ya da çalışırken sürekli bir aksiyon istiyor, heyecan istiyor ama düşünün 9 defa sahaya doktorun girip çıktığını ya da sağlık ekiplerinin girdiğini çıktığını düşünün. Ortalama bir tedavinin süresi ki bu zaman zaman 30-40 saniyede girip çıktığımızda olmuş. 5,5 dakikaya uzayan tedavi süreleri de olmuş. Ortalama yaklaşık 1,5 dakika sürmüş. Bu da şu demek arkadaşlar. Herhangi bir Türkiye Ligi için konuşuyorum. Maç izlediğiniz zaman ortalama 5 dakikaya aslında biz sadece sağlık ekiplerinin içeri girip çıkmasıyla harcıyoruz diyeyim. Ya da işte zaman zaman elbette ihtiyaçlar oluyor ama birazdan da zaten onu konuşacağım. Bu süre artıyor. Bu Dünya Kupası maçlarında baktığımız zaman erkeklerde 97 saniye, erkek Dünya Kupası'nda kadınlarda 108 saniye ortalama çıkmış. Elbette burada yabancı misafirlerimiz önünde şunu demek isterim. Biz Türk hekimleri olarak içeri girip çok hızlı bir şekilde tedavi ediyoruz. Yabancı meslektaşlarımıza göre. Halbuki muhtemelen senaryo biraz daha işin içerisinde daha basit olaylar için girmemizle alakalı olabilir. Bu sürenin Türkiye Ligi'nde daha kısa olması. Şunu merak ettik elbette. Peki biz içeri girdik. Tedavimizi yaptık, müdahalemizi yaptık, tanımızı koyduk. Oyuncuların ne kadarı maça devam edebiliyor ya da ne kadarı maçtan ayrılmak zorunda kalıyor? 3 aşağı 5 yukarı aslında tahminleriniz vardır. Bizim tahminlerimizin oldukça altında çıktı. Yaklaşık %17'si oyuncuların sadece bu tarz problemler için bir sahaya girdiğimizde dışarı çıkmak zorunda kalmış. %82'si o sihirli spreyi sıktırmış ya da işte bir şekilde tedavisinde olmuş, maça devam etmiş demek anlamına geliyor. Şunu da merak ettik. Evet, %17'si çıktı. Peki bunlar gerçekten bir sakatlık sonrası mı acaba çıktı? Çünkü bazen yorulan sporcu da, yorulan futbolcu da oyundan çıkmak için bir şekilde bunu kullanabiliyor. Ya da zaten oyundan çıkacağını bilen oyuncu sakatmış numarası da yapabiliyor. Gerçekten de bir sonraki maça baktığımızda oyuncuların sadece %8,4'ünün bir sonraki maçı kaçırdığını görmüş olduk ki bu hakikaten içeri girişlerimizin demek ki %91,6'sı aslında çok da ciddi olaylar olmadığını gösteriyor. Biz bu makaleyi yayınladıktan sonra çok sevdiğim bir dostumuz bana bunu attı. Aslında Fransızca da bilmiyorum. Kendisi bana tercüme etti. Diyor ki Fransızca bilenler varsa anlamıştır. İşte fotoğrafta dünyanın en iyi aktörünü görüyorsunuz. Hemen sağında da Arnold Schwarzenegger. Gerçekten de evet bazı futbolcular maalesef diyeyim bu tarz yaralanmalara biraz daha yatkın oluyorlar diyelim. Literatürle uyumlu bulduğumuz bir takım verilerimiz de var elbette. Mesela nedir? Bunlardan bir tanesi gerçekten de futbol evet kontak bir spor, sürekli bir temas söz konusu ve bu yaralanmaların yaklaşık 3'ü aslında travmaya bağlı ani kontak yaralanmalar dediğimiz yaralanmalar ve hemen hemen yarısı da alt ekstremiteyi ilgilenen işte ayak bileği, diz, baldır gibi yaralanmalar oluşturmuş. Bizim için aslında hekimler olarak önemli olan kafa travmaları aslında. Yaklaşık 1/4'ü bizim sahaya giriş nedenlerimizin aslında kafa travmaları ile ilgili. Bunlarla ilgili şimdi birkaç tane enteresan bilgi vereceğim ama ona geçmeden önce şunu söyleyeyim. Biz yine takım doktorları ya da işte takımlarda çalışan kondisyonel arkadaşlar, atletik trainerler onların çok ilgilendiği bir konu kas yaralanmaları. Bizim bu çalışma genelinde bulduğumuz kas yaralanmaları verilerimiz aslında yine literatürle uyumlu çıktı. Yaklaşık yanlış hatırlamıyorsam 54 tane kas yaralanmamız vardı ki bu tüm yaralanmaların %5'iyle tekabül ediyor ve 1000 maç saatine göre baktığımız zaman 6,1 civarında bir kas yaralanma sıklığı var ki bu gerçekten demek ki hakikaten gerçek sakatlıklar gerçek olarak da bu çalışma esnasında görmüşüz ama onun haricinde bir dünya fake diyebileceğimiz yaralanmalar olduğunu da gördük. Az önce bahsettim yaklaşık 1/4'inin kafa olaylarıyla işte kafa travmalarıyla ilişkili olabildiğini ki 232 tane kafa yaralanması meydana gelmiş bu 266 maçta. Neredeyse her maçta bir defaya yakın bir kafa travması söz konusu olmuş. Peki bunların ne kadarı gerçekten ciddi? Çünkü bu FIFA ya da işte kural koyucu mekanizma gerçekten bu konuda çok hassas. Özellikle sporcuların kafa travmaları sonrasında müdahaleleri konusunda hakemler de oldukça hassaslar. Ki muhtemelen bu da zaten olumsuz kullanılan durumlardan bir tanesi. Evet, baktığımız zaman yaklaşık 5 yaralanmadan bir tanesinde sporcunun işte dudağı kanamış, kaşı açılmış, kafa travmasının kafa derisinde bir kanama olmuş. Ya gerçekten evet, tıbbi bir müdahale gerektiren durum olmuş. 5'te 1'inde. Kalan %80'ini değerlendirdiğimiz zaman peki ne olmuş? Şuna baktık. Bir kafa travması sonrası, bu bir kanama olabilir ya da konküzyon gelişmiş olabilir. 232 yaralanmadan kaç futbolcunun maça devam edemediğini inceledik. Şaşırtıcı bir rakam aslında. Sadece 7. Yani tüm kafa travmalarının sadece %3'ünde sporcular maça devam edememiş gibi. Bu aslında bize şunu gösteriyor. Birçok sporcu, özellikle işte son kurallardan sonra hava topuna çıkıyorsunuz. Eğer ki diğer rakibinizin eli kafasında değerse işte sarı kart gösteri vesaire. Birçok sporcu bunu maalesef kötüye kullandığını, aslında bu bile çok basit bir şekilde bize göstermiş. Bunlar bizim çalışmamız esnasında görülen, işte o 7 sporcudan bir tanesi mesela mandibula kırığı. Bu tarz yaralanmalar da elbet oluyor ama dediğim gibi %97'si aslında maalesef kötüye kullanım gibi görülmüş oluyor. Peki gelelim benim oğlumun bakış açısı doğru mu? Gerçekten de ben meslek olarak içeri girip sprey sıkıp çıkan bir adam mıyım? Baktık ne kadar tedavileri de bu arada hem kendimiz kaydetmiştik hem de sonrasında maçları tek tek izledik, bu tedavileri ekrana yansıyan görüntülerinde. Tedavileri tekrardan kontrol ettiğimizde şunu gördük. Her 3 girişimizden 2 tanesi aslında evet o meşhur soğutucu sprey ya da işte ice pack'i kullanarak olmuş. Gerçekten de benim oğlum haklı gibi duruyor. Ama bu bizim aslında yaptığımız işi çok da küçümsemememiz gerektiğini gösteren, nadir de olsa hemen hemen herkesin başına gelebilecek meslek kariyerinde umarım kimse yaşamaz ama durumlardan bir tanesi. Birazdan Giulo da muhtemelen bununla ilgili bahseder. Son Avrupa Şampiyonası'nda işte Eriksen'in yaşadığı olay ve sahada yığılıp kalması ve ona benzer birçok olay olması bizim için, hekimler için ve sadece hekimler için değil aslında. Hepimiz için, yani bu salonda bulunan, futbol sahasının içerisinde bir parçasında olan hemen hemen herkes için çok önemli bir durum var. Temel yaşam desteği konusunda hem bilgilerinizi güncel tutmak hem de bu konuda eğitilmiş olmak ki benim hakikaten hassas konularımdan bir tanesidir. Çalıştığım kulüplerde mutlaka personel eğitimine de bu konuda çok zaman ayırmaya ya da en azından çeşitli kurslar vermeye, eğitimler vermeye ki işin uzmanları tarafından bunu organize etmeye çalıştım. Çünkü bir takım doktor olarak ben her zaman ya da işte herhangi birimiz her zaman kulüpte bulunamayabilirsiniz ama her an başınıza bu tarz bir şey geldiğinde sizin de ilk müdahale yapacak kadar olaya biraz hakim olmanıza fayda var. Benim başıma bir defa geldi. Rize Spor'da çalışırken bir sporcumuz da yine Giulo burada kardiyolog olarak, Arrhythmogenical olarak bir atrial filatura öyküsü denk geldi. Tipik testere dişi görüntüsüdür bu. Hatta internete bir anda işte küçük şehir sonuçta koroner yoğun bakımına gitti hasta. Sporcu hemen biz ilk müdahalesini yaptık. Tanıdan şüphelendik. Ambulansla hastaneye gönderdik. İşte kalp krizi geçirdi diye haberler çıktı vesaire ama hani O'Brien şanslıydı. Kısa bir sürede sinüs ritimle döndü medikal tedaviyle ve kariyerine de devam edebildi ki hatırlarsınız daha bundan birkaç hafta önce sadece Kunagüero benzer bir tanısını direkt olarak bilmiyorum Agüero'nun ama o da böyle bir ritim bozukluğu sebebiyle dünyanın en üst düzey futbolcularından bir tanesi maalesef sporu erken yaşta bırakmak zorunda kaldı. Elbette sadece saha içindeki olaylar değil, saha dışında da birçok şey oluyor. İşte aslında sabahki konuşmada Antalyalı, arkada Antalyaspor'da çalışanlar buradaydı. Antalyaspor maçları hep benim açımdan şey geçmiştir, böyle enteresan geçmiştir. İşte hakemlerin sakatlığı olabilir, teknik direktör problem yaşayabilir. Bazen tribünde birisi kalp krizi geçirebilir, özellikle salon sporunda çalışıyorsanız. Bu yüzden birçok senaryoya hakim olmakta fayda var. Hatta ben kendim rekreasyonel futbol oynayan biri olarak defalarca sahada işte kendi takım arkadaşıma ya da rakibimize ilk müdahale yapmak durumunda kaldığım zamanlar oldu. Çalışmamızın bence en çarpıcı bulgularından bir tanesi, bunu özellikle sona sakladım. Maç esnasında tüm bu 266 maç esnasında skora göre sahaya girişleri değerlendirdik. Bu şu demek, aslında tüm maçların hemen hemen yarısında skor berabere devam etmiş. Şimdi ne beklersiniz? Demek ki eğer ki bu iş adil bir şekilde ya da düzgün bir şekilde oluyorsa tüm sakatlıkların yarısının skor berabereyken olmasını, kalan 1/4'inin kazanan takımı, 1/4'inin de geride olan takıma ait olmasını beklersiniz. Ama şunu gördük, skorda önde olan takım oyuncuların %38,5 oranında çok daha fazla bir şekilde tedavi ihtiyacı olduğunu gördük. Takımı geride olan futbolcuların ise %14 kadar, neredeyse 3 katına yakın bir şekilde daha az tedavi ihtiyacı olduğunu gördük. Bu aslında bize o mesajı veriyor ki, asıl mesajı veren şurası. Son 15 dakika içerisinde ki gerçekten bir maçı izlerken belki de en fazla sinir, hele ki tuttuğunuz takım gerideyse insanı en fazla irite eden durumlardan bir tanesidir. Son 15 dakika içerisinde baktığınız zaman özellikle takımı önde olan futbolcuların çok daha fazla tedavi ihtiyacı gerektiğini görüyorsunuz ki muhtemelen işin gerçekten olması gereken kısmı %13 civarında işte takımı geride olan sporcuların yattığı oran. Bir bulgu daha bulduk. Aslında bunu makalede, yayında çok bahsetmedik ama sizinlerle paylaşmış olayım. Kültürel etki de kesinlikle olduğunu düşündük. Aslında buna yönelik de biz araştırdık. Gerçekten sahada aldıkları süreye göre baktığımızda Türk oyuncuların, özellikle bu bizim kendi belki kültürümüzde ya da oyuncu eğitimlerinde buradaki Türk arkadaşlara belki bunu eğitmek de lazım. Aldığı süreye göre tedavi isteme ihtiyacının diyeyim çok daha fazla olduğunu anlamlı bir şekilde özellikle Avrupalı meslektaşlarına göre ki hani hep böyle özendiğimiz Avrupalıların daha dürüst olması ya da işte biraz daha daha fair oynamasıyla alakalı bir durumdur belki de. Gördüğünüz gibi Türk sporcuların çok daha fazla bir şekilde sahada yattığını maalesef gördük. Bu Afrikalı ve ilgimizde oynayan Afrikalı ve Güney Amerikalı futbolcularda aldıkları sürelere göre hemen hemen aynı olarak saptanmış. Şunu söyleyeyim, henüz daha bu yayın aşamasında dediğim gibi Dünya Kupası verilerini de incelemiştik. Dünya Kupası verilerinde hem erkekler hem de kadınlar Dünya Kupası'nda Afrikalı futbolcuların diğer kıta sporcularına göre biraz daha fazla aldıkları süreye göre tedavi ihtiyacı olduğunu da eklemiş olayım ama bizim ligimizde böyle bir olay çıkmadı. Son iki video örneğiyle konuşmamı bitireceğim. Fenerbahçe'nin maçı, işte son dakikalar, durum 2-1. Fenerbahçe'ye yabancı arkadaşlar istiyorum. Ülkenin en iyi takımlarından bir tanesi. İki tane oyuncu pozisyonu, pardon şunu tekrardan geçireyim. Baskı yemiş durumda takım. İki oyuncu işte görüyorsunuz kayarak müdahalesini yapıyor. İkisi de milli takımlarda uzun yıllar oynamış. Çok en iyi, hani mevkilerinde en iyi Türk oyunculardan iki tanesi. İşte golü yemiyorlar, bir şekilde oyun devam ediyor. Çok enteresan ve çok dramatiktir aslına bakarsanız. Sonrasında işte pozisyon devamında her ikisi de kayarak, sürünerek yavaş yavaş saha içerisine geliyor ve hakemden tedavi ihtiyacı istiyorlar. Sonuçta hani bunun o anda acil bir durum olmadığını aslında stat'taki 50.000 kişi dahil, işte hekimler dahil hepimiz biliyoruz aslında ama bu oldukça rutine binmiş bir şey. Yine aslında bu konuda çok yorum yapmamam lazım çünkü benim geçen seneki takımım, yani benim halefim mi oluyor? Halefim sağlık ekibiyle alakalı biliyorum. Birkaç hafta önce Türkiye Ligi'nde bir sağlık görevlisi sarı kart gördü. Mevzu da şu aslında, oyuncu birazdan oyundan çıkacak. Hakem bunun farkında ve şeye inanmıyor, gelme diyor. İstemiyorum çünkü hani ciddi bir durum yok. Zaten oyuncu çıkacak. Biraz da işte o anın adrenaliyle sağlık görevlisi içeri giriyor. İşte hakem kartla cezalandırır ama hani devil is in the detail demek lazım çünkü o da farkında aslında içeri giriş sebebi bir şekilde oyunu durdurmak, soğutmak. Saha kenarında olmak evet gerçekten çok keyifli bir şey. Burada elbette teknik direktörün rolünü çalmıyorum. O dönemde tercümanlarımız ikisi de Covid'de ben yardım etmek zorunda kaldım. Birçok şeye aslında orada müdahale olmak zorunda kalıyorsunuz. İşte çeşitli, çoğu zaman seviniyorsunuz, zaman zaman gözyaşı döküyorsunuz. Ama genel olarak şunu söylemek lazım. Bizim hani tıpta evet temel prensiptir. Hastanıza asla zarar vermeyin. Az önce bahsettiğim O'Brien olayında kariyerin belki de unutulmaz anlarından biriydi diye. En unutulmaz ikinci anı da göstereyim size. Kendi kendiyle şaka yapan kişi olsun diye. Geçen sene başıma böyle de bir şey geldi ama nispeten Pinto şanslıydı. En azından herhangi bir zarar vermedim. Ben spor hekimliğinin gelişmesinde ülkemizde çok değerli katkı olan başta Emin Hocam ve bugüne kadar benim eğitimimde katkıda bulmuş tüm hocalarıma, asistan arkadaşlarıma hepsine çok teşekkür ediyorum. Dinlediğiniz için de hepinize çok teşekkür ediyorum. Çok sağ olun.
Thank you, Gürhan. Very colorful presentation. Thank you. Now, ladies and gentlemen, we have a very special guest. He is very special because he is a cardiac surgeon, someone who can hold the heart in his hand. So, thank you for accepting our invitation, Dr. Giulo Pompilio. I'm sorry to mispronounce it. So he's a professor in cardiac surgery, finished his residency program at University of Milano with summa cum laude, which is a very high degree. If you are an academician. I'm sure you know about that. And his actually age index is 35, really very high. He has published 225 scientific articles in different journals. Dr. Pompilio is the head of vascular biology and regenerative medicine at Monzino Cardiologic Center, as well as he is the scientific director of this unit. Along his clinical work, he is very involved in research activities, including cardiomyopathies, which is one of the main problem occurring during the sudden cardiac death of the athletes. So he's going to talk about the sudden cardiac death, the treatment and prevention, of course. So he is he has a very long CV. I'm sorry, I have to stop here. Otherwise, I need to continue on to down, Dr. Giulo. So as a cardiac surgeon, we're going to listen to him about his very recent research activities and the projects. So he raised funds up to 2 million, 3 million euros, which is again very convincing, very striking figures, convincing activities to the European funds. So saving life is utmost important compared to winning the match. So floor is yours, Dr. Giulo.
Well, thank you. It's too much. Thank you, Professor, for this kind presentation. I will try in 20 minutes to follow up what was previously said about cardiac death and cardiac issues in athletes. But before this, let me thank, first of all, Nicola Innocentin of Global Football Service for the kind invitation. Is the reason why I'm here. And they found the Association of Patients, the Unbeatables, which are the patients which support partly our research. The environment where I work is in Italy, in Milano. I work in a standalone cardiovascular center, which is the biggest center in Italy for cardiovascular care. Belongs to the network of Ministry of Health in Italy and is affiliated to university. It was ranked first in Italy and 17th in the world as a cardiologic center. But beside these figures, these metrics, I think what is important to say, and it was already said, that beside the clinical activity treating patients, we do a lot of research. And these figures means you nothing, but they mean that we are cardiovascular center #1 in Italy doing research in cardiology. And part of our research is devoted to cardiomyopathies and athletes. I'm not a sport medicine doctor. I am a cardiology and a cardiac surgeon, so I'm not so expert in sport medicine. But we see more and more athletes, professional and non-professional athletes with cardiologic issues. That's why we started to be interested in doing research and care in professional and non-professional athletes. And then we established a sports center, which is Monzino Sports Center. This is the largest cardiovascular sports center in North Italy, and has today many patients, thousands of patients. It's affiliated to the Italian Olympic Committee, and we receive professional teams, consultancy, advice, as well non-professional competitor come to us for second and third level sport cardiology consultancy, which is something that is becoming more and more frequent, at least in Italy, as advice after having received the first sport medicine outpatient consultancy. And then one problem related to cardiology and sport is sudden cardiac death. As you have seen before, the images, the clip of Ericsson in this year, last year, sudden cardiac death is not only a problem for the general population, it's a big issue in the general population, and the main issue in older patients over 45 years, the cause is coronary artery disease, which is basically an obstruction in the vessel that bring the blood supply to the heart. But this is not, of course, a sport issue. What we see in athletes, in young athletes and also in older athletes, is that sudden cardiac death is due to basically two issues, two problems that are inherited. So they belong to the genetic disease population, the genetic conditions that affect the heart. And the two problems are cardiomyopathies, which is basically a heart muscle degeneration, and channelopathies, which basically are disorders of the electricity into the heart. So these two conditions are very important to determine cardiac death, sudden cardiac death in professional and non-professional athletes. And that's why it's important to do, of course, care, prevention, and research on it. So this complex pie is the distribution of the determinants of sudden cardiac deaths in young non-professional athletes. Non-professional. So the majority, the largest cause of sudden cardiac death is HEM, Hypertrophic Cardiomyopathy, which is a genetic condition, as I said, involving the heart. And then we have abnormalities of coronary arteries. And then, so these two conditions are account for more than 50% hypertrophic cardiomyopathy and coronary artery abnormalities. And then we have other less frequent genetic disorders like ARVC and ion channelopathies that belong to the cardiomyopathy that I have alluded before. Why young non-professional athletes? Why? Because these causes of sudden cardiac deaths are found in athletes that are not checked at the professional or competitor level. Normally in children that practice sport, like football in Italy, without any important check. So small children. And the small children die for sudden cardiac death for something which is easy to detect, very easy to detect. Both conditions like coronary artery abnormalities and hypertrophic cardiomyopathy is something which is easy to see in a cardiologic check like we normally do. What it's important to say is that for athletes, for those who are checked, not the general population, but those who are checked, the problem may occur without any warning sign. It means that as many of 80% of cases of sudden cardiac deaths occur in asymptomatic patients, even if these athletes have been checked. Can we prevent it? Of course, how? Doing diagnosis. We need to identify the problem. With this algorithm, we do, as usually is done, a pre-participation screening for the basic participation of competitor sportive, like children. So this screening is the first screening. It's a basic screening and include personal history, familial history, ECG, exercise test, as you know, spirometric test, and urine test. Then, for cardiology, you need, if something is not okay, you need a secondary level test, which basically raise the bar to echocardiography, monitoring of ECG, blood test. Think about master athletes, blood tests of cholesterol is very important, for instance. And then you should also take into account the tertiary level screening, especially for professionals, in which cardiac magnetic resonance, CT scan, and genetic test must be, if needed, must be conducted. One thing that have to be said that as far as we know, there is a lack of international consensus about the cardiology assessing in athletes. And you know that because sometimes it happens that a football player is not clear to play in Italy or in a country, and then it's clear to play in another country. This means that the international consensus of the level of diagnosis is lacking. As my predecessor has mentioned, in athletes, professional athletes, if you go to Wikipedia, there is a long list of athletes that died playing or in activity, even if they, of course, have been checked. And why this? Why the long list of athletes dying of sudden cardiac deaths? It's because we lack a good diagnosis. Of course, it has been said that immediate assistance in the pitch with CPR, cardiopulmonary resuscitation, and defibrillation, it's mandatory. Ericsson teaches this story very well. But also, it's mandatory to increase our knowledge on prevention and diagnosis in the cardiology arena as for professional athletes. Why? Because basic screening may not detect a problem. The basic screening can detect a lot of issues, but not everything. And also for professional football players, the basic screening is not enough. There are initial stages of hypertrophic cardiomyopathy or subtle cardiomyopathies and electrical disorders, or subtle inflammation in the heart that can be not well seen in a basic screening test. For instance, myocarditis. This is a recent story of the player Agüero of Barcelona. He has been diagnosed with a small inflammation in the heart that causes arrhythmias. And myocarditis is one of the tiny, can be very subtle. The sign into the heart can be very tiny, but the problem that it can cause can be very important. And Agüero is an example. And someone can stop playing and could also die playing for something which is very, very small to detect. Another issue is hypertrophic cardiomyopathy, which is a disease in the heart that causes thickness of the walls of the heart. Thickness, sorry, I cannot point out that the heart becomes thick. And in the initial stage of the disease, this can be not seen very well at the basic screening. And then what we know and we are looking for, it's a genetic disease which is caused by, it's not important the name of the genes, but just to let you understand that in this cardiomyopathy, the 40% of people are not recognized by genetic testing, which is a lot. So we know a lot about the genes are responsible for this condition, but not enough. And we need to do research on that because we need to identify more genes in order to be able to detect the condition, the genetic disease, as accurate as possible. Another problem is this condition is the long QT syndrome, which affected the ECG. This is more easily seen in a basics test, can cause cardiac arrest and during exercise. It's another cause of sudden cardiac death in athletes. And also in this case, there is a part, about 30% of people involved in this condition which are not identified by genetic testing. Also in this case, we need to conduct more research. And the other condition is Brugada. Brugada, it's a well-known condition that can cause syncope or cardiac arrest during sleep or fever, but also during exercise. Has a typical pattern at the ECG, but as you can see here, the vast majority of patients are not detected by the genetic test. So this is the reason why we need to do more research on these guys to identify more genes involved in the condition. And then finally, and the reason I'm here also here to talk to you, this is another condition which is in athletes, in footballers, a known cause of sudden cardiac death. It's called Arithmogenic Cardiomyopathy, which is a strange name to say that the heart undergo a structural deterioration and the muscle becomes fat. And the electricity into the heart is not good, becomes crazy. And this condition is a known cause of sudden death for professional athletes. We know a lot of genes involved, but many are not known yet, so we are doing research on that. One example of this condition is Davide Astori from Fiorentina. We died for a sudden cardiac death and was diagnosed of arrhythmogenic cardiomyopathy. So, there are two things to be said at this stage. First, we need to have for athletes, non-professional, professional athletes, a strong genetic program to detect those genes which are involved in the condition you have said. So now we are able to detect multiple genes with new technologies, third generation, second, third generation of sequencing. We can basically, in a cheap way, sequence the entire genome. With 500 euros or less, we can sequence the human genome of every one of you with 500 euros. It's not too much. And maybe in the next years it's 100 euros. So it's very cheap, it's very fast, but at the same time, the information we get are too many. And then we need to digest the information and try to limit the information we get to the problems we are looking for. And then what is needed for athletes, it's a cardiogenetic program in which you have counseling, so you test the athlete and for instance, the children, if a father or the mother is recognized to have a cardiac problem like that, they have to be tested. But not only tested, they have to be accompanied to the process after the with counseling before the test and counseling after the test. And also we need to do research on that to understand, to identify more genes involved in these conditions. So what we do is doing genetic tests in athletes which are suspected to have a cardiomyopathy, but also we do research to identify new genes. And then there is another issue, not only genetic testing. It's also important to do research at the lab level, experimental research. Why it's important? Because experimental research is the link between the patient, the athlete, and the information we need to find out new therapies. So we need to diagnose well with genetic testing, we need to do prevention, but also we need to do research. And in 5 minutes, I will explain you why. So do you remember ACM, the condition, the arrhythmogenic cardiomyopathy, the fat degeneration, the cause of death of Davide Astori? So we are doing a lot of research on that and using patients in our hospital. And what we discovered, the disease turns, this is normal heart, this is muscle. And this is what happens in the heart of Astori, for instance. The muscle turns into fat. This is a genetic disease, and it's very difficult in early phases to be detected. And what can you do? You can do magnetic resonance to detect, and you see here the white sign. This is fat in the heart of an athlete, which was stopped, a football player. And then from this athlete, with his consent, we took from him inside the heart cells, and we studied the cell of this athlete. And we found that the cell in the blood, and we found that in this condition, this molecule, which is called oxidized LDL, it's a molecule related to fat in the heart and in the blood. So we have found that in this condition, for the first time, we found that in this condition, the level of oxidized LDL, so the oxidation of this molecule, it's very linked to the severity of the disease. And it's linked to the infiltration of the fat into the heart, but it's also linked to the severity of the depression of the capacity of the heart to pump. And if you identify a cutoff, so those guys who have this molecule high in the blood, and those guys who have this molecule low in the blood, you see the survival. So this guy have high level and they die earlier, much earlier than the guy who has low levels. So we have discovered in the lab a protein which is linked in athletes, which have been stopped, to the severity of the disease. But not only this, we have also found a possible therapy, because this molecular mechanism that causes the oxidation of FDL can be targeted with a therapy which is now available. The drugs are the statins, which are drugs that are commonly used to lower the cholesterol level. Statins, you probably have already heard about statins. Millions of people in the world use statins, not for these purposes, but just to lower the cholesterol level. So what we have done, if we have tested the statins at the lab level in the cells of the patients and in the animal models, and we have understood that just simply taking this drug, which is available, can lower down, attenuate the severity of the disease and prevent sudden cardiac death. So, and I'm going to finish, a transition from a research work, as we are commenting now, and the readout in patients can be done going from the lab, we say from the bench, to the bedside, to the patient. How? Once you have identified a molecule, a target to be addressed by a drug, you can test it again in patients. And then this is what we are aiming to do. We are aiming to do a clinical trial testing in these patients this new drug, in order to lower down the progression of the disease. So we think to have in our hand a possible new drug to treat these patients. And this condition is typical of sportsmen, typical of sportsmen. So what we will do And that's one of the reasons I'm here, is to tell you that from Monzino we are building up a clinical study which is Europe-wide, will involve 16 centers in US and Europe. Turkey is not not here yet, but I would love to have also a Turkish center. And we have already designed the study. We are submitting the proposal to the European community. And the study will test the capacity of this drug, which is atorvastatin, which is a very, very, very commonly used drug in the cardiology setting, to treat the disease and ameliorate the prognosis in these patients. Of course, research needs money. This trial has been budgeted for about 8 million euros, which is not trivial, and then that's why we are looking for money. But I think this is a clear example how sport medicine, cardiology, and then research can be linked together to do tentatively to make improvement for our patients. And that's it. So thank you. Let me thank the group, my group, and the people in the lab that worked every day with passion in these projects, and especially Elena, which is my deputy head. Without her help, nothing could be done in our research. Thank you very much for your attention.